Welcome, everybody. As we let everybody in, please feel free to enter your name and your organization and location into the text chat if you like. And you might also want to share why you decided to join today's webinar, what you're hoping to learn. We'll start in just a few moments. I'm seeing a couple of notes that the chat is disabled. We'll get that fixed in just a moment. Thank you. Looks like the number of participants coming in has slowed down, so I think we can go ahead and get started. Chrissy, over to you.
Great, thanks. Thanks everyone for joining us today. I'm Chrissy Giuliano, Executive Director of the Big Cities Health Coalition. The Big Cities Health Coalition, or BCHC, is a forum for leaders of America's largest metropolitan health departments to exchange strategies and jointly address issues to promote and protect the health and safety of the more than 61 million people they serve. Elizabeth, if you could go to the next slide. Together, as you can see on the map, these public health departments directly affect the health and well-being of about 1 in 5 Americans. So our 35 member jurisdictions are listed here. Nearly 30 years ago, a group of big city epidemiologists created the Big Cities Health Inventory, or the BCHI. They published chart books on a semi-regular basis to share information with peers in other jurisdictions so they could benchmark city-level indicators against each other. In 2015, we relaunched the BCHI as an online platform with funding from CDC, the Centers for Disease Control and Prevention. In 2019, we partnered with the Urban Health Collaborative at Drexel University's Dorn Snai School of Public Health, who you'll hear from soon. The Urban Health Collaborative was created to leverage the power of data, research, education, and partnerships in order to make cities healthier, more equitable, and environmentally sustainable. The team at Drexel that you'll hear from today has managed the day-to-day work on the BCHI and the upkeep of the platform over the last several years. Shortly, we'll discuss some key new features of the platform, which you can find at bigcitieshealthdata.org. We'll drop that link in the chat also, so feel free to open it up and follow along. I do want to share that the platform is primarily supported by CDC through a cooperative agreement with the National Association of County and City Health Officials, or NACHO. Our BCHC staff time is supported by a number of health philanthropies from whom we have ongoing grants. All that said, the views expressed here do not necessarily reflect the views of CDC, NACHO, or our foundation funders. So now that we've gotten that out of the way, over the course of the next hour, we'll talk more about this, but we at BCHC really believe that data are needed at the local level, and in our case, not just the county level, but often the city level, so that you can view trends at a local municipal level to inform policy decisions and identify policies that are working or may not be. So really thinking about that small p political jurisdiction is important when looking at data points. So I'll stop there for now. I'm going to turn it over to the team at Drexel. If questions arise during the conversation, please feel free to put them in the Q&A box. We'll answer them later in the webinar. So I'm going to turn the baton over, or hand the baton off to Dr. Amy Auchincloss from the Drexel Urban Health Collaborative. Amy?
Thanks, Chrissy. Welcome, everyone. I'm so glad you're here. Thanks for taking the time. I am Amy Auchincloss. I'm an epidemiologist at Drexel University School of Public Health in Philadelphia, and I'm a lead on the Big Cities Health Coalition data platform that is housed at the Drexel Urban Health Collaborative. So the Drexel Urban Health Collaborative leads and supports a number of projects that focus on urban health in cities across the nation and across the globe. And you'll hear from some of our colleagues today. So I'll give just a 1-minute overview orientation to the platform before we get started with the demonstration. So we have over 120 metrics on the platform, including about over 150,000 data points. The metrics cover these 11 categories shown on the right, and you'll see these same categories on the platform. The metrics were chosen because of their public health relevance, specifically alignment with healthy people goals and benchmarks for new policy initiatives, as well as more broadly metrics that could highlight demographic and socioeconomic disparities in health and healthy environments. Many of the metrics that are on the platform were on, some version of them were on the prior BCHC's prior versions of the platform that Chrissy just talked about. New metrics that we recently added: preterm births, colorectal and prostate cancer deaths. These are coming from the NVSS, the vital records from CDC at the federal level, and vaccinations, COVID vaccinations also from the CDC. Currently, our data platform includes 2010 through 2021. We've recently added the 2021 data, and we update the platform as new data, the data sources release new data. Most of our data sources are from the US government in order to ensure that data are uniform and comparable across the cities. We currently have 35 cities, which is the BCHC. We only are showing BCHC member jurisdictions on the platform. The majority of our data are city level, which is a unique feature of our platform. City is the smallest geographic aggregation that we are showing on the platform. You'll see shortly that users can visualize data in a single year or trends over time. We can share pre-populated charts on social or just with your colleagues, and you can directly download much of the data that is viewable on the platform as a download CSV file. We've created some products using the platform as a way to illustrate the kinds of things that users can look at or can analyze and think about on the platform. This is a list of briefs and infographics. We've recently updated a drug death infographic. I'll show you that quickly at the end. And we're working on updating our gun death brief as well. So I'll turn this over to Saima Niamatula, and just for anyone that needs to pop off, we are available anytime. Please contact us on email, and we will get back to you as soon as we can. And Saima will also share that there's a survey that pops up, and it's just a couple of questions. It's another way to connect with us.
Thanks, Amy. Hi, everyone. I'm Simon Yamatullah. I'm the data manager for the Big Cities Health Inventory. Today, I'm going to walk you over, for those of you who are new to the platform, I'm going to walk you over the different ways you can view the data for your cities. So this is the homepage. The link should be in the chat. You can directly go to your city by clicking on the cities and the map in the homepage. On the top, you see the 4 different ways we can view the data for the big cities. First is explore a big city, compare cities, view a metric, and inequities. First, I'll use the view a metrics page to demonstrate the different ways that the data are available in the platform. First, we need to choose a metric. When you click on the pop-up window, we have over 120 metrics, and all the metrics are given in a categorized list in the 11 categories that Amy mentioned. So for example, if you want to look at data for colorectal cancer deaths, I'll click on chronic health conditions. Under cancer, we have colorectal cancer deaths. We have also the metrics are given in the drop-down menu as a list. The bar is also searchable. You can type in keywords like cancer or death, and all the relevant metrics will come up. The second, we have to choose a city. I'll choose Houston. So you see the charts populate, giving the different ways that the data are available in the platform. The first chart is the trend in colorectal cancer deaths for Houston. On the x-axis are the years. Currently, we have the data from 2010 to 2021. The second chart is the colorectal cancer deaths for 2021, a single year. It's a bar chart. The trend lines and the bar charts are the two different main types of charts that are visuals that are available on the platform. You can also view the data for population subgroups. So here we have the colorectal cancer deaths by race. So we have the data for Hispanic, non-Hispanic whites, the blacks, and Asian and Pacific Islanders. The data are available by other population subgroups, like by race, by sex, and by race and sex. So if you want to view the single metric for a city in details, the view a metrics is be the feature to use. If you want to view multiple metrics for a single city, we'd use the explore a big city. First, we have to choose a city. I'll choose Houston again. There is a short city blurb, which gives some socio-demographic information about the city. This page pre-populates with some default metrics for all available years. The first chart is the trend in COVID-19 deaths. So for COVID-19 deaths, we have the data for 2020 and 2010. The next chart is the single year data for COVID-19 vaccination for 2021. If you want to change the years of data, you can use a year. And if you want, you can use the group by to view the data for population subgroups, like for race. We can get rid of metrics by clicking on the red cross at the side. We can add more metrics to the page by clicking on the add metrics. Here, I'll add colorectal cancer deaths again. So here we have a trend in colorectal cancer deaths. I can change. We can also view the colorectal the data by racial subgroups for the time trends. We can add as many metrics to this page as we want. There is no limit to the number of metrics that can be added. So this was viewing multiple metrics for a single city. We can compare the metrics across different cities by using the compare cities. For comparing cities, first we need to select a cities. I'll choose a primary city and the cities for comparison. We can choose either all cities or a subset of cities. First, I will choose all cities. The second step is selecting a metric. I will choose preterm births. So this is the data for preterm births in 2021 for all the BCHC cities. The y-axis are the cities. We also have a US total reference line for the overall US value. You can sort the data using the sort by from high to low values. To put the cities into context, you can also group cities based on a number of characteristics like region, poverty, population density, or segregation. So here we see the data are classified on less poor cities at the top and the poorest cities at the bottom. We can also change the years of data to see other years of data that are available. We can view the time trends and compare the data for population subgroups, but only if less than 7 cities are selected. On the next tab, I have a selected subset of cities as few metrics. So here we can see the preterm births. When you select all years, you can compare the trends across different cities. And if I group by race, you can compare the racial inequities in poverty across the different cities. So in this page also, you can add more metrics and you can view multiple metrics when you compare different cities. The next feature I will show you is the inequities. So this is to view racial and ethnic inequities for some of the platform's metrics to understand the difference between groups. In this page, we currently only have the mortality metrics, but we are going to add other socioeconomic metrics in the near future. So here too, first I will choose a metric. I will choose prostate cancer. And here we can select either all cities or single city. I'll choose all cities first. So this is the racial and ethnic inequities in prostate cancer in 2021. The different panels are the different races. So the first panel, the blue bars are for the Black-white difference in prostate cancer. The green bars are the Hispanic-white difference in prostate cancer. You can see like a number of cities are missing data because these cities do not meet the minimum criteria for the number of deaths that is required to publish data. And the third panel is the Asian-white difference in prostate cancer. So this, for the inequities, we also have the cities in the y-axis. The central axis is at 0. A value of 0 means there is no difference in rates between the Hispanic and white. Inequities can have either negative or positive values. So if, for example, if the bar for Philadelphia is pointing to the right, that means in Philadelphia, the Hispanic population have a higher death rate from prostate cancer when compared to white population. And for Las Vegas, the Hispanic population has a lower death rate from prostate cancer when compared to the white population. Each of the bar represents the absolute difference in values. When you hover over the bar, the box gives a short description of the value. You can also view the data for single city. In this chart, all the differences are given in the same chart. We can for inequities, we cannot look at the time trends, but you can change the year for which to view the data. Some other capabilities in the platform are the share, where you can share a pre-populated web page. All the charts are downloadable by clicking on the hamburger. You can download the chart as a PNG, JPEG, or a vector image. The data are downloadable as Excel format. So you have the link to the download page is given here below. So remember to scroll all the way down to come to the download, for the link to the download page. We also have some other pages like what's new, about, and the FAQs. In the FAQ, you can find more details about the metrics and the methodologies. And we have a link to a technical documentation, which gives the metric definitions in details and the methodologies and other details like the different sources of data used and the years for which the data are available. We'd love to hear from you. So this is our email address at which you can contact us. And like Amy mentioned, we are also conducting a survey at the moment to collect information to improve the user experience and you add meaningful data to the platform. We hope you will take the short 2-question survey. I'll turn it over to you, Amy.
Thanks so much. That was great. I'm going to just quickly show you the what's new page. So from the home page, there's a what's new section, and we've pinned the data download just to make it a little easier for you to find. And this webinar from today will be posted here. So for any colleagues of yours that weren't able to join us, let them know they can see it here. And there's some other demos that folks can look at on how to use the platform. And our briefs and infographics are here. I'm just quickly going to look at the infographic that we recently released that's showing the exponential rise across the big cities in drug overdose deaths. And this is being largely attributed to the rise in illicit synthetic opioids like fentanyl. This final panel is averaging the values across the cities and showing some trends that the CDC is also reporting nationally. The gray bar is 2010 and the red is 2021. So in 2010, the highest overdose death rates were among white people. You can see here is highest and the gray bar is highest. And in 2021, Black people had the highest rate of overdose deaths in the red bars here. And you can see the huge increase in Black deaths recently due to drug deaths. So this is averaging across all cities. So there's quite a lot of heterogeneity, differences in the city rates. You can go to compare cities and click on the cities to show I'll put it in here, drug. Here you can see there's wide heterogeneity in the rates of drug overdose deaths across the cities. And to get a sense of the trend over time, although you'd have to just look at a subset of cities in order to actually get the visualizations of trends, but you can kind of jerry-rig it by looking at drug overdose deaths on 2 panels and 2010 in one panel and 2021 in another. You can see the huge rise in drug deaths across all cities by even looking at the x-axis here shows a 3- or 4-fold increase compared to the x-axis in 2010. So this is, another way to look at the between city contrasts in the data. So we are so happy that you guys have joined us. We are very, very hungry for feedback and input on the platform. So please let us know what your thoughts are and anything you'd like to see, anything that's not working. If anything looks a little messed up on the platform, refresh the URL. And sometimes we're seeing that we're going to get some things fixed. Sometimes the labels get a little bit off, but if you refresh the browser, the URL, you'll get to the right, it'll refresh to the right display. And I'll turn it back to Chrissy if you want to, or Elizabeth, if you want to lead any of the Q&A. Should we just read off, or Elizabeth, what is, I see, we can see them.
Yes, I'm going to start with a question that we got in the Q&A actually. Emily Long is wondering if you could talk a bit about the technology that was used to build this platform.
Yeah, so the data are from the federal sources, and those were downloaded, they were all downloaded. The NVSS, the vital statistics data, we do have to get special permission to access those data from the CDC, the city level data. Once we download them, we're processing the data in statistical computing software in SAS and in R, and then uploading them to the site. The building of the site was a separate vendor that we worked with named Lincoln Loop. They've done a great job. They've used a open source software, Django, and it's hosted on an Azure platform. I'm not sure how if you want more details on the tech specs, please reach out to us, or if there's any additional questions. I don't know how technical that you wanted that answer to be.
Yeah, probably some of that probably would be good in a separate conversation, but so actually kind of a related question that we received during the registration process. Are there any plans to expand to other cities or expand the metrics in any way?
So I can start by answering the city question. So we are the Big Cities Health Coalition. We have 35 members, which are based on city size. So our members are cities that have 500,000 people or more as the city population. So the member is the health department that serves that city. So we have about a little less than half of our members are county health departments that serve cities. And also in our membership criteria we include that it must be an independent local health department. So in a number of states across the country, local health departments are actually employees of the state. And because of the work we do, the members have felt it's important for us to add that to our membership criteria. So at this juncture, we are not planning on adding additional cities to the platform unless and until we add additional members. On the metrics question, we continue to add metrics each year as they are relevant to the work of the coalition and sort of the public health field more generally, and as data are available at the city level. I think Amy can talk a little more about this, but there are a number of metrics that we've been trying to find good enough measures to look at things like climate change and things like that, again, at the city level, and where data can be available for, at least a critical mass of our 35 jurisdictions. So, we sort of use 15 perhaps as the minimum, because we do want to make it relevant across the coalition's members. Amy, I don't know if you have anything else to add on the metrics.
No, that's it. Yeah, and I think too there's an advisory panel, so there's a bunch of vetting. I think we had a couple of questions come in early about sort of the relevance of the metrics and how they're decided. So there is a vetting process of proposing, both from BCHC side, our side, as well as all of you. So please, if there are things that you would like to see, and we will see if we can get them. There are limitations in terms of our ability to get data that's standardized across all jurisdictions or most of the jurisdictions. For those of you I saw some climate change or environmental health folks in the chat. If there's anyone that's particularly interested in climate metrics and some of that relate to the climate emergency, please reach out to us. We will be launching, hopefully in the coming year, some metrics related to that.
So a related question that's also a bit more specific comes from Maria Palma. She's asking, do you have any insights on when the USDA will be updating the Food Access Research Atlas data? And do you have any suggestions for measuring the food environment with more current data?
Yeah, that's an interesting question. Maybe there's somebody on the call actually that knows the answer to the updating the USDA database. We do not have the answer to that. they are accessible, that group, or the folks that the CDC or the liaisons with the CDC. If you wanted to reach out to them, send them an email. The data, as you can see from the metric on that, is we've actually used track. So we're not displaying any track level data, but in some instances, the segregation metrics, the food environment metrics, we are utilizing track level data and then summarizing that to the city. So the proportion of tracks or the proportion of neighborhoods in the city that have low access, thing like that. Most people have used the CDC actually did a nice brief a few years ago. You can probably find it by searching CDC food environment metrics. They did a nice brief on different data sources for food environment, for characterizing food environments. That is, I would encourage folks to look at.
Thank you. So a question that's sort of a little more about using the platform. Anne Pham is asking in the Q&A, will CSV downloads include information about error that aren't in the visualization?
Yeah, and Simon can also speak to this, and I think Chris O'Malley also has a question about statistical analysis related to comparisons. So the comparisons would, some statistical analysis of comparisons between cities would require some of the error characterization, the confidence intervals, and the uncertainty. And that is, we don't display that on the visualizations, but that is, the confidence intervals are included in the download for many of the metrics, particularly the NVSS metrics that were calculated.
Gotcha. Thank you.
And we're happy to answer any follow-up questions around that on email or later. Yeah.
Great. Thank you. Another question from the Q&A from Shadi Chamani. Any plans to allow for some of the disease mortality to be looked at using premature mortality? I see all cause has a premature option, but not specific conditions. Understanding small cell sizes may be limiting for some, but for those causes of death with large numbers, maybe?
Yeah, we've had I think you're right. We've had some trouble. I mean, the bigger cities, Los Angeles, New York, Chicago, San Francisco, certainly we probably could get that. It's just that we're trying to meet also the cities like Columbus and some smaller jurisdictions. So yeah, Simon, maybe you can respond to that, whether I think we've had trouble, and also with life expectancy, we've had some trouble meeting, having enough data because of the different age ranges that are required. So premature mortality also requires some of the age buckets that have to be filled across.
But I think that's an interesting proposition we have. Like we do have some of the metrics, like for the cause of death, which have larger death counts. Maybe we could perhaps, maybe we can think about it for next year.
Good, great. Well, we might reach out to, that was Sadi Chamani. Are you? We'll find out. Great. Thanks.
I can get their information to you. Question from the chat from Lucas Ayers. Are there any advocacy efforts for CDC to publish data at the independent health jurisdiction level as opposed to the county level? This would have been especially useful during the COVID-19 pandemic. Amen. It seems like something they'd be able to do if states are reporting data to them by the local health departments or local health jurisdictions. Chrissy, I think you said you might want to take that on.
Yeah, I would say, Lucas, you're preaching to the choir with this group. So yes, I will say that my colleagues and I have many conversations with CDC about this. To be fair, there are some structural issues for CDC to really be able to do this. They don't actually have the authority to require such reporting. And that's one of the things that we have advocated with Congress on, is to give CDC the authority to collect data, not in a public health emergency, which was how they were gathering much of that more local data during COVID. But you're absolutely right. It's not, most CDC data is at the county level. That's one of our challenges in doing this platform. And we continue to talk to them about why it's important to think about, as I think I said in my opening, small p political jurisdictions, right? If you are in a large, if you're a large city in a large county, frankly, the mayor of that city doesn't care about the rest of the county, right? She is making decisions about the health of his or her population, not, the whole county at large. So for data to be actionable and reflective of the community, we really do need to focus on having more national level data systems have smaller jurisdictions, or not smaller jurisdictions, but sort of smaller points of analysis, and really looking at cities in addition to counties.
And perhaps you've sort of answered this already, but I think there's maybe some additional sort of angles to this question. John Auerbach had asked during the registration process, what are the major challenges to data modernization that big cities are facing? I think you sort of addressed some of that question, but maybe there are additional aspects to it.
Yeah, I mean, this is clearly, we could do a whole webinar just on this, right? So there are data challenges that we just talked about, and then there are sort of resource challenges, and those include literally building data systems and having the resources to do that. It includes having the workforce to be able to build and use those systems, and being able to compensate that workforce that frankly is not necessarily, sitting in a public health department somewhere, all due respect to all UFEs that are out there, but, really bringing in a different type of workforce. And so you're competing with the private sector. And lastly, doing retraining of folks that are in the workforce. So, if you are an EPI sitting in a health department and you really want to focus in on, more on informatics or things like that, figuring out what that skill set is needed and what capacities are needed, and then being able to, again, retrain and build that workforce. So it's super complicated, but it really starts with both tangible resources and the workforce, and thinking about how we can make sure that all health departments across the country, from the local, state, and federal level, have the ability to do so.
Great, thank you. Rex has just posed a question. I have an unstable connection, so I'm not sure if you saw this question. It would be, sorry, I probably shouldn't have read that part. I'm seeing it now, Rex. It would be interesting to link the BCHC policy awards like smoking, et cetera, to this data to see if there's any correlation. I'm not sure.
Yeah, that one of the downsides of the platform is that there's a delay. This isn't current year data, so we are reliant on mostly the feds posting data, and there's usually a delay. There's also, for some of the metrics, such as some of the NVSS metrics, there's some we actually aggregate across we have the current year, and then we have 2 neighboring years in order to build data support. This is a common technique using a 3-year sort of moving average of the time of the for the metric. So there is some challenges with looking at sort of a pre and post type of scenario with policy, but in long-term changes we can see, and there has been a pretty sharp decline in the colorectal, one of the new metrics, the colorectal cancer deaths, pretty much across most cities and across most race groups as well. So there's probably some interventions going on at the city and also at the federal level that are accounting for that. Smoking trends, yeah, we continue to see declines in that, and whether we can see some more sharper declines during the period where some of the localities were implementing local smoking bans and things like that, and also price ranges and increases in taxes. Our platform could be used for that. That the smoking data or some of the behavioral data are coming from CDC as well, and many of the cities have their own sources for those data as well.
Yeah, and I would just add that those data are among the hardest for us to get to be comparable across the cities. Amy and I were just having this discussion yesterday. You know, a lot of that comes from the behavioral risk factor surveillance survey. And then there's one that also looks at youth, the youth
risk factors.
Thank
Yeah.
you. I was drawing a total blank. And the YRBS specifically does not cover the whole country. So there are, you know, there are data sources that could be more robust, which would start to allow us to do that. But the time lag is also real, as Amy mentioned.
One other question that we've received is about how much of this data has actually been shared with community groups, or how much, you know, to what extent they've accessed it. I'm not sure if we, you know, have information on that, but she's asking, you know, in order to sort of check for context and relevancy and actionability, you know, to what extent this data is sort of getting to community organizations.
I mean, our jurisdiction, I think, Chrissy, you can speak to this. Our community are the health departments, the local health folks. So Chrissy can describe a little bit how the broadcasting of sort of new metrics and the feedback loop between how we decide on new metrics and all of that, whether it reaches the more lower level community groups, that is, yeah, we are not necessarily that connected to those groups, although we do have some folks reaching out to us periodically, and we're trying to support whoever is interested in the platform. So if there's something that you or organizations that you know are interested in a particular thing, please let them ask them to reach out to us. One of the things that within cities, many people are looking for neighborhood level data, and that's not going to be on our platform. So our platform is best at comparing across cities rather than in characterizing local neighborhood level metrics.
Yeah, and I would just a couple of things I would add. I mean, you know, the founding goal and the ongoing goal of this work is to be able to look across cities. You know, historically and even now, we've found that our member jurisdictions have different challenges than potentially neighboring counties in their states, right? There are structural things about being an urban environment that affect the health of communities. And so this allows them to look at similarly situated jurisdictions and say, oh, you know, let's look at, you know, 20 years ago, the HIV rates, right? If you were comparing across a state in counties, it was different than cities. So that has been sort of the primary purpose. That said, there are tons of metrics at the city level that anyone, this is fully public, fully open access data platform. So anyone can use the platform, can download the data. And as Amy said, we're always interested in hearing about needs and wants, though I hesitate to say that, but you know, if there are metrics that perhaps, whether it's a local health department or an advocacy group or community-based organization, a metric that somebody's collecting locally, we can see if we can do it. You know, we have sort of our teams collaboratively are fairly small, but we want to make sure that we're, as we've talked about, sharing the right new metrics. We just don't always have the data available for the metrics we want to share. So long story short, absolutely, we encourage anyone and everyone to use this. And if there are things you'd like to see, you know, reach out to someone on our team.
We'd also love to hear about ways that you've used the data in this platform to, you know, if it's supporting research or you know, programming at the local level. I think it would be, you know, we've certainly seen examples of that come up in over time, but would love to hear about more of those.
And if you do use the platform, fill out the survey. So that's one of the ways that we gather these data. And, people never want to fill out surveys. I always, skip through surveys too, but that is one of the ways we gather information around who's using it when we think about next steps. So if you do visit the platform today, tomorrow, fill out that quick, 1 minute survey, and that would be super helpful.
Great. Well, those are the questions we've received so far. I know we've had questions from a few people about will the presentation be made available, and yes, we will send out the presentation and a link to the recording to everybody who registered shortly after this webinar ends. And yeah, we appreciate your.
And it will be in our What's New section on our website, and sometimes it's on the BCHC's home, one of their pages as well.
Yes, well, thank you all so much for being here today. I will just quickly put up our last screen here so that you can have our contact information. This is how you can reach the data platform directly. That's the website address at the top, and then our Twitter handles are just underneath. Well, Chrissy, Amy, and Simon, thank you so much for presenting today, and Walker, thanks for running the webinar for us, and thank you all for being here.
Thanks, everyone.
We have